Good morning. Thank you so much for this opportunity to speak today and provide this historical perspective on inhibiting the HIV-1 reverse transcriptase enzyme. I am pleased to have this opportunity. I think that this is how you know you're getting old, when people start asking you to give the historical perspective. But it's been fun to think back and reflect really on the history of reverse transcriptase inhibition. My disclosures are shown on this slide. And in the next 15 minutes or so, I'll be reflecting on the role of RT therapy. And I want to start the story just taking you back to the beginning of the HIV pandemic, when the first cases were reported from Los Angeles in 1981. And at that time, we really had no idea what was going to become of this infection. We didn't know what caused it. We had no idea how widespread it was and of the devastation that would follow. I think many of us have been reflecting back to the beginning of HIV over this past year as we face the global pandemic of coronavirus. And many of the lessons that we learned when combating HIV have been really, we've marshaled some of those resources and some of those responses to try to deal with COVID-19. So in 1981, when when AIDS was first described, took 3 years before we even knew the causative agent, HIV-1, a retrovirus. So that was a long time when people were sick and we didn't know for sure what the cause of the disease was. And I think that reflecting back, what was also true is there was this sort of predominant feeling that as a retrovirus, this was going to be very difficult to treat. Retroviruses were really not thought to be pathogenic in humans. They've been rare exceptions where they were causes of T-cell leukemias. And the idea that the virus integrated into the host DNA was really thought to render this untreatable. So efforts to think about therapy, we faced a really big uphill battle. And AZT, the dideoxythymidine, was the first agent that was shown to have in vitro activity against this new virus. The history of AZT is an interesting one. It was first synthesized at the National Cancer Institute in 1964 as an anti-cancer drug. In 1974, it was shown to have activity against the murine leukemia virus. And this is what led to people looking at it, particularly the group at the NCI, Sam Broder, and colleagues, and its activity was demonstrated then in 1985, so 4 years after the first cases of HIV, they demonstrated in vitro that this drug could inhibit the replication of this retrovirus. And this led to a partnership between investigators at NCI, at Duke, and at Burroughs Wellcome, who took on the development of this agent for clinical use. At this time, when AZT was first shown to have activity, December of 1986, we had 28,000 cases of AIDS in the US, and half of the people who'd been diagnosed had died. Almost 80% of those who'd been diagnosed before 1985 had died. And this is a reflection of the fact that people were diagnosed very late in the course of disease based on their clinical presentations, and we had really limited interventions. So when the first studies showing the clinical benefit of AZT came out in 1987, it was really a landmark development. Being able to show that an antiviral drug could slow the clinical progression of a disease, so reducing the progression to AIDS-defining illnesses over a period of months was really a major step forward. Now in retrospect, it seems like the clinical activity was fairly limited, but at the time, it really opened the door to the idea that we could treat this disease. It was also around this time that research groups were forming, and one in particular, the AIDS Clinical Trials Group that I've been associated with since the early days, was started in 1987. It was established as an AIDS treatment evaluation unit, and it was an alliance of academic, industry, government investigators, all working together, importantly, with community representatives. Was funded by the National Institute of Allergy and Infectious Diseases and other collaborating institutes, and the group participated in some of the pivotal studies of nucleoside reverse transcriptase inhibitors, both alone and in combination. And this really set the stage for the ability to do drug development studies rapidly across different areas. So not too long after the activity of AZT was demonstrated, we began to see some of the limitations of monotherapy with this class of drugs. And the first reports of HIV with reduced sensitivity to zidovudine were reported in 1989, so just a couple of years later. Interestingly, in this first report, the clinical significance of drug resistance was not yet fully appreciated, and it was acknowledged that it was unclear what the clinical significance would be. I mean, we soon learned that resistance really did limit the efficacy of monotherapy and led to the development of combination therapy with these classes of agents that were all RT inhibitors. This was a very dark time in the history of HIV. While we did have a therapy and other RT inhibitors shortly followed after AZT, the ability to prolong life significantly was somewhat limited. And at this time, by 1994, 93, 94, AIDS in the United States was the leading cause of death for people the ages of 25 to 44. And this was really kind of the worst time in the HIV pandemic because of the limitations of the therapy that we had available. We were starting to appreciate development of resistance as well as a range of toxicities that limited the long-term use. So as was noted, AZT was approved in 1987, and following upon that, other RT inhibitors came into use, didanosine and DDC, and then stavudine or D4T in 1994, which was thought to be less toxic in terms of bone marrow suppression. And really in 1995, when lamivudine or 3TC was approved, I think was the beginning of a turning point, because this was when combination therapy with combinations of RT inhibitors really began to show a benefit. The first non-nucleoside RT inhibitor, nevirapine, was approved in 1996. And but at this time, we also really began to fully experience the number of toxicities related to thymidine nucleosides and mitochondrial toxicity, but then other toxicities from these agents, including renal insufficiency, rash, and hepatotoxicity, importantly with nevirapine. We had many challenges in treatment, when to start treatment and who to treat. We struggled with how to maximize the benefit of these time-limited therapies. We focused a lot of effort on preventing and managing drug resistance through the use of combination therapy, toxicity through the use of dose reduction, and even the consideration of treatment interruptions as a way to manage both resistance and toxicity. Concurrently with these developments, progress was being made in the treatment of and prevention of opportunistic infections. And it was really the culmination of these activities that led to the combination therapies that paved the way for what was called the era of highly active antiretroviral therapy, or combination therapy, including nucleosides and protease inhibitors that came onto the scene in 1996. In retrospect, this sharp decline that we saw in the rate of death to AIDS in the United States following from 1995 to 1997 was attributed to the emergence of combination therapy, including protease inhibitors. But I think the combination therapy with nucleoside RTIs, as well as improvements in prophylaxis, also contributed to what soon became rapid declines in improvement in life expectancy. These developments subsequently, additional agents in both the nucleoside or nucleotide RT inhibitors and the NNRTIs became available, and continued development to improve toxicity and improve efficacy followed. Newer generation agents that were developed had less toxicity, could be used long-term in combination. And then in the NNRTI class, we saw the development of new agents that had a higher barrier to resistance and lower rates of toxicity. So in conclusion, just this perspective, these RT inhibitors, and specifically the dideoxynucleosides, offered the first evidence that it was possible to treat HIV. And I think in retrospect, I don't know that we fully appreciate, how much of a challenge that was at the time. The studies of AZT monotherapy documented the ability to improve clinical outcomes, and also importantly, the ability to prevent transmission. The prevention of transmission, of perinatal transmission with AZT that was published in 1997, I think really led the way for thinking about the use of antiretroviral therapy for prevention between individuals and not just perinatal prevention, and led to the development of pre-exposure prophylaxis. I think it's also important to reflect that the clinical research infrastructure to evaluate new treatments emerged in response to these early discoveries and provided the scaffold for continued progress. The identification of resistance, which was described early on, prompted the use of combination therapy and revealed some important insights into viral pathogenesis. Certainly, toxicity ultimately limited the long-term use of the first generation NRTIs, and I think as we'll hear more today about the use of therapy without NRTIs has emerged from these concerns about toxicity. But I think that it is important that we acknowledge that RT inhibitors really set the stage for the revolution in HIV therapeutics that followed. So thank you very much, and I'll be happy to answer questions.